Hello, everybody. I'm Dr. Sarita Rao, Senior Intervention Cardiologist from Apollo Hospital, Indore. And today we're going to talk about the day one updates from ACC Chicago. Now, typically, we're looking at 5 very interesting trials which have come up in the day one. That is, the first is the SOUL randomized trial. We're looking at oral semaglutide, which reduces the CV events in people with type 2 diabetes with atherosclerotic cardiovascular and or CKD. The second interesting trial we're looking at is the DAPA-TAVI trial, that is the dapagliflozin in patients undergoing transcatheter aortic valve implantation. The third, which we are looking at, is the primary and the secondary outcomes of the women ischemia trial to reduce events in non-obstructive coronary artery disease, the WARRIOR trial results. And fourthly, the effect of the once-weekly subcutaneous semaglutide on the functional capacity in patients with type 2 diabetes and peripheral arterial disease. These were the results from the STRIDE trial. And lastly, we're going to be looking at the main results of the phase 3 REVERSE-IT trial. So let's look first at the SOUL trial. The design of this trial and the objective of this trial was to assess the CV efficacy of oral semaglutide with regards to the risk of MACE compared with placebo in patients with type 2 diabetes and at high risk of CV events. Now, this was a double-blind, placebo-controlled, event-driven superiority trial, and they randomized assigned patients who were 50 years of age or older and had type 2 diabetes with a glycated hemoglobin level of 6.5 to 10. They also had known atherosclerotic cardiovascular disease, CKD, or both, and they received either once daily semaglutide, and the starting dose was 3, and they hiked it up at 4 weeks to 7, and then another 4 weeks to 14 mg, and then they compared it with a placebo in addition to standard of care. The primary outcome was major adverse cardiovascular events, a composite of death from cardiovascular causes, non-fatal MI or non-fatal stroke, and assessed in a time to first event analysis. The secondary outcomes was a 5-point kidney disease outcomes. They also looked at CV events. Now, there were 9,650 participants who had undergone randomization. The median follow-up was 49.5 months, and when they looked at it, the primary outcome event occurred in 579 of the 4,825 participants in the oral semaglutide group, as compared with 668 of the 4,825 participants in the placebo group. And the results for the confirmatory second outcome did not differ significantly between the two groups. And the incidence of serious adverse events was 47.9 in the oral semaglutide group and 50.3% in the placebo group. The incidence of gastrointestinal disorders was 5% and 4.4% respectively. So they decided, based on the results of this trial, that oral semaglutide reduced major cardiovascular events by about 14% in patients with type 2 diabetes over nearly 4 years. And oral semaglutide was superior to a placebo in reducing the incidence of the 3-point MACE in patients with type 2 diabetes and ASCVD and or CKD. There was also a consistent CV efficacy of oral semaglutide across the various subgroups by age, sex, BMI, eGFR, and concomitant medication. The overall safety profile of oral semaglutide in the SOUL was similar to that observed in previous clinical trials with semaglutide, and no new safety signals were found. The trial results add to the favorable benefit-risk profile of oral semaglutide in this population. It is the first and only GLP-1 receptor agonist with proven CV benefits. The second trial, which was very interesting, was the DAPA-TAVI trial, which enrolled 1,257 patients undergoing TAVR at 39 Spanish hospitals. The participants had an average age of about 82 years, and interestingly, in this trial, half were women. All the participants had previously been hospitalized for heart failure and had severe aortic stenosis. Participants also had at least one other condition that put them at high risk of poor health outcomes, such as diabetes, either a poor kidney function or a low left ventricular ejection fraction. They were looked at 3 months and at 1 year, and the primary endpoint was a composite of all-cause death or worsening heart failure. The secondary endpoints were again all-cause death, hospitalization for heart failure, or an urgent heart failure visit which required diuretics, cardiovascular death, and composite of hospitalization for heart failure or cardiovascular death. So at 1 year, the rate of the study's primary endpoint, a composite of all-cause death or worsening heart failure, was 28% lower in patients taking dapagliflozin. This statistically significant improvement was attributed to a 37% reduction in worsening heart failure among those taking dapagliflozin. Again, among elderly patients with aortic stenosis undergoing TAVI and at high risk for heart failure, dapagliflozin was safe and reduced the incidence of all-cause death or worsening heart failure as compared to the standard of care. The women's ischemia trial was the third trial, and they looked at to reduce events in non-obstructive coronary artery disease. The concept was that intensive medical therapy would reduce primary outcome and first occurrence of MACE by 20% versus usual care at a 5-year follow-up. This is the largest trial in the INOCA field, and it documents the high burden of recurrent angina hospitalization. Sensitivity analysis incorporating contamination at both arms demonstrated a non-significant 25% MACE reduction, potentially supportive of an effect that had sufficient statin and ACE-ARB been utilized. The results extend prior literature suggesting that ACE-ARB treatment in INOCA to a goal of a systolic BP of less than 120 may be best for the SAQ angina reduction. Typically, the Warrior trial was showed that among women with suspected INOCA intensive medical therapy, it actually failed to significantly reduce the first occurrence of MACE versus usual care at 5 years. And this was typically symptomatic women with suspected INOCA at 71 US medical centers and randomly assigned to receive intensive medical therapy, which consisted of a high-intensity statin, an ACE inhibitor, or an ARB at a maximally tolerated dose and low-dose aspirin, and the other half had received usual care. This trial enrolled about 2,476 patients. It had a median follow-up of 5 years, and the mean patient age was 61.2 years, and all of the patients, 100% of the patients were women. And there was not a significant difference in the primary outcome in the intensive medical therapy arm. That's 17.84 versus the usual care arm, 16.17 when it came to MACE. And this was primarily driven by hospitalization for chest pain. In the secondary outcomes, there was not a significant difference in the secondary outcomes, which included, again, quality of life, time to return to duty or to work, healthcare utilizations, angina, cardiovascular death. So typically, the Warrior is a neutral trial and showed no significant difference in MACE in the intensive medical therapy versus the usual care arms. But it's important that patients with risk factors for coronary artery disease should have their risk factors evaluated and treated with high-intensity lipid-lowering agents and or ACE inhibitors or ARB. Furthermore, this trial is also that evidence that additional studies are required in assessing the female population with INOCA, as they are considered to be a vulnerable population. The next trial that we are looking at is the STRIDE trial, and we know about the potential mechanism of GLP-1 receptor agonist benefit in peripheral arterial disease. We know that GLP-1 receptor agonists have a great role to play. They decrease the HbA1c, they reduce the weight, the inflammation, the blood pressure, they reduce the kidney complications, and macro and microvascular benefits are also there. STRIDE typically was a double-blind randomized placebo-controlled trial done at 112 outpatient clinical sites in 20 countries in North America, Asia, and Europe. All the participants were 18 years and older with type 2 diabetes and peripheral arterial disease with intermittent claudication. They were Fontaine stage 2A, and they were able to walk greater than 200 meters and had an ankle brachial index of less than or equal to 0.9 or a toe brachial index of less than or equal to 0.7. Patients were randomly assigned 1:1 using an interactive web response system to receive subcutaneous semaglutide 1 mg once per week for 52 weeks versus a placebo. The primary endpoint was the ratio to the baseline of the maximum walking distance at 52 weeks, measured on a constant load treadmill in the full analysis set. Safety was evaluated in the safety analysis set. So basically, in this entire 1363 patients were screened for eligibility, of whom 792 were randomly assigned to semaglutide or placebo. And about 25% of the participants were female. The median age was about 68 years. And there were 6 serious adverse events in 5 participants in the semaglutide group and 9 serious adverse events in 6 participants in the placebo group, which were possibly or probably treatment related, with the most frequent being serious gastrointestinal events reported by 2 in the semaglutide group, and 5 events were reported by 3 in the placebo group. There were no treatment related deaths. So basically, semaglutide increased the walking distance in patients with symptomatic peripheral arterial disease and type 2 diabetes. Research implications include the need for future studies to further elucidate mechanisms of benefit to assess the efficacy and safety in patients with peripheral arterial disease who do not have type 2 diabetes. When we talk about summarize this, there was a significant improvement in maximum walk distance and also the pain-free walk distance, which is similar in magnitude to cilostazol, which is class 1, and they met pre-specified criteria for a clinically meaningful change. Significantly improved in all supportive secondary outcomes, including 2 quality of life measures, and there was a reduction in progression requiring rescue treatment and improvement in the ankle branchial index. Again, like I've said, the limitation of this trial that patients without diabetes were not included and should be studied in future trials. Then we come to the REVERSE-IT study design. That this was a multi-center, open-label, prospective, single-arm study of the reversal of the antiplatelet effects of ticagrelor with bentracimab. Now, bentracimab is an IV monoclonal antibody which rapidly reverses ticagrelor in about 5 to 10 minutes. And this was done in 226 patients with the use of ticagrelor within the prior 3 days who would require an urgent surgical procedure or who present with major bleed. The primary endpoint was percent inhibition of the P2Y12 reaction unit, that is the PRU. And the secondary endpoint was effective hemostasis, independently adjudicated by the Clinical Events Committee. And when you look at the results of this trial, in patients undergoing urgent surgery with or without a major bleeding, bentracimab significantly restored the platelet function as measured by the PRU. Hemostasis was effective in the majority of cases, as assessed by an independent adjudicators in both of these groups. There were no serious allergic, thrombotic, or other events which were related to the bentracimab per the adjudicators, confirming the safety profile which was seen in the phase 1. Based on the results of the REVERSE-IT, bentracimab appears to be a very promising option for ticagrelor reversal. There's ongoing regulatory assessment of bentracimab, and the FDA has granted orphan drug designation as of last week. Ladies and gentlemen, thank you so much.